Good evening, everyone. I am Arpita from the IGCP group, and I welcome you all to this insightful session on unplanned pregnancy in diabetes, navigating the management maze. Managing pregnancy in women with diabetes presents unique challenges, and when unplanned, these complexities multiply. Today, we are privileged to have with us Dr. Bharti Karla ma'am, an esteemed expert in gynecology, to guide us through a case-based discussion on this crucial topic. Ma'am is a consultant at the Bharti Hospital, Karnal, where she has been at the forefront of maternal health and diabetes care. In this session, ma'am will walk us through real world cases, shedding light on risk assessment, treatment adjustment, and evidence based management strategies. With her expertise, will help us decode the best approaches to providing holistic and individualized care. Now, without doing further ado, I would now request ma'am to start with her presentation. Over to you, ma'am.
Thank you for this opportunity. And this is a very common topic, and in day-to-day practice, everyone finds it difficult sometimes because everyone must be getting the younger patients of diabetes, and in reproductive age group, they are coming with the pregnancy test positive, and either they are excited or they are upset or they are worried. So today we will discuss about it. In day-to-day practice, yesterday I got a patient. She was 16 weeks pregnant and she wanted termination because of her uncontrolled hyperglycemia. She told me, Doctor, I am in perimenopausal age group. I thought I am getting menopause. I have heard that in diabetes you get early menopause. But how come I am pregnant and at this gestation, what can I do? My HbA1c is 9%. And another patient, you get a newly married who is type 1 diabetes, and because of her marriage and all celebrations, she was unable to control her blood glucose and comes with pregnancy test positive. So she is concerned whether I should continue it or not, what can be the complications. So these two types of scenario where it is just burden on someone and another one wants to get pregnant, but in these challenging circumstances, she is unable to cope up with it. So as this is in my first slide, I find it like unprepared trying to climb a mountain, means climbing a mountain in high heels. So, so what should we do? So just going about the unplanned pregnancy, this is defined as the pregnancy that occurs either when woman wanted to become pregnant in future but not at this time. That means this is a mistimed pregnancy, or the one that occurred when she didn't want to become pregnant at all and the child is a burden on her. This is unwanted pregnancy. So, according to Indian NFHS survey, NFHS 5 survey, the 25% of pregnancies in India are unplanned, whether these are welcome or not, and what is your partner's attitude in deciding whether this should be continued or not, and if needed termination, when it should be planned for termination. Just quickly going through what is diabetes and pregnancy. In pregnancy, diabetes can present either before it or during pregnancy. If it is diagnosed before start of pregnancy, maybe type 1, type 2, or any other type of diabetes, or the hyperglycemia which is diagnosed in pregnancy with the values which are in range of diabetes in non-pregnant state. Means in first trimester, if we test her for hyperglycemia, she gets the reports of fasting plasma glucose more than 126 and casual or postprandial more than 200 milligram percent, which are the by definition in the range of diabetes. Another condition of gestational diabetes means diabetes during pregnancy or because of pregnancy, means hyperglycemia diagnosed during pregnancy, which value are not in diabetic range, means fasting less than 126 and postprandial more than 140 but less than 200, means in the range of 140 to 200. And because of pregnancy, if hyperglycemia occurs, it is usually beyond 24 weeks of gestation. But nowadays, it can occur earlier in pregnancy also. So, for diabetic women, what is unplanned pregnancy? Means she didn't get time to get preconceptional planning that aims to optimize her medical, endocrine, emotional, and social health. Whether in such conditions pregnancy is welcome or not, and what is her partner's attitude. And before taking any decision, we have to say what is her health status and what is her health care status. Means whether she can visit her clinician frequently, get regular antenatal checkups done or not. So all these things are to be considered while planning for her pregnancy, continuation of pregnancy especially. So the challenges in unplanned pregnancy in diabetes are emotional, social, and financial. Very important because repeated visits, repeated investigations, extra investigations need to be continued during pregnancy. Medical complications for the mother and her obstetric status may be difficult. Obstetric complications may occur, and the neonate who has to brunt the consequences of hyperglycemia may be early in pregnancy or later in pregnancy or during its birth. So, how to assess it? First of all, when the patient presents to us, we have to confirm the pregnancy and the gestation. As the two extremes I have already discussed in the examples, what is her obstetric status? Means she already has children, or this is her first pregnancy, or she had suffered many abortions and she is desperate to continue this pregnancy. What is her emotional readiness and social support with us, with her partner, her family members, and her clinician and their staff? So, which kind of social support she gets, whether they are willing to listen to her with all her, maybe someone may thinking that these are the silly complaints, but whether that kind of support she gets or not. And on medical aspect, what is her glycemic status, whether she is continuing on and other concomitant medications, what are her comorbid conditions and complications of diabetes, and above all, we shouldn't forget the fetal health. That is the first and foremost important. In her obstetric history, we have to look for her previous obstetric complications, whether she get GDM or PIH in the past. Many a times in last pregnancy she got GDM and afterwards she became careless or she was not guided properly and she was liberal with her weight as well as her hyperglycemia. She never bothered. And this time when she comes with unplanned pregnancy, she is she has flare up of her symptoms and full-fledged diabetes. Her previous obstetric outcomes, and ease of conception. If she has conceived with IVF or very difficult or ART procedure, then she will like to continue it at any cost. So, about her medical history, how long is she has diabetes, and what was her control? Means her HbA1c level is an important marker. Does she get repeated hypoglycemia, or in long-standing diabetes, does she have diabetic complications like retinopathy and nephropathy? At certain stage of hyperglycemia, the retinopathy and nephropathy rapidly worsen during pregnancy, and her neuropathy status. If she is having autonomic neuropathy, there are chances of other complications also. And what is her cardiovascular status? And we must review her medication status, whether she is taking any teratogenic drugs during her pregnancy for her concomitant diseases or complications of pregnancy. As we see in diabetic nephropathy, mild to moderate renal dysfunction, one can continue, plan and continue. If it has already occurred, one can continue that pregnancy. No deterioration occurs, but if she gets superimposed preeclampsia, then the things may rapidly worsen. But if moderate to severe renal dysfunction is there in early pregnancy, the rapid deterioration occurs. In those cases, we give priority to her health over and above the fetal status. About retinopathy. Ideally, proliferative diabetic retinopathy should be diagnosed and treated before conception with laser photocoagulation. But if we are not able to achieve this before conception, if she has minimal retinopathy, we have to check it in every trimester. But if moderate background retinopathy is there, on every visit, means every month she has to get it checked to look for any worsening. And about proliferative retinopathy, for its high risk characteristics, she will need laser photocoagulation that the eye surgeon will decide whether we can do it during pregnancy or not. But otherwise, it shouldn't be done during pregnancy. But at that stage, we have to weigh her vision versus complications during pregnancy. And at times, if the things are very bad, we have to plan for cesarean delivery. In my 25 years of obstetric practice, I have done just one patient cesarean for worsened proliferative retinopathy. In that case, we had to treat her very judiciously with the cesarean delivery had to be done for to prevent her blindness. Psychosocial history, we have to look about her attitude towards fertility, her attitude and her family's attitude toward termination of pregnancy. Some of the religions they don't allow termination at all, come what may. So in those cases, we have to take consideration. Her social support and economic status are very important. What about trimester specific concerns? These were general concerns. We have to look holistically. And if she comes to us in first trimester, first of all, we like to look for whether the pregnancy at this stage is viable or not, whether she should it is continuable or not. And sometimes a lady who is on oral hypoglycemic agent for her hyperglycemia control, and we want to shift her to insulin because if the control is poor, we want her to start insulin in the very first day. But before that, we must get ultrasound done to look for what is the status of her pregnancy, whether it is viable or not. So early pregnancy confirmation scan should be done. If things are going well in first trimester, then we have to look for congenital malformations because uncontrolled hyperglycemia is an important risk factor for certain congenital anomalies which are over and above the general population. So early anomaly scan at 12 to 13 weeks, TIFA scan, and fetal echo should be done timely. And if any anomaly which is incompatible with life, then we should think of termination of pregnancy. And for fetal growth, we should get repeated scan at 28, 32, and 36 weeks. And gestational weight gain appropriateness. If the gestational weight gain in early half of pregnancy is higher, then there are chances of worsening of hyperglycemia. That means we will need higher doses of insulin or higher doses of medication and repeated visits, and the complications of pregnancy will be higher. So, in that case, we must appropriately chart her gestational weight gain and we have to guide her about diet, calorie intake, and exercise so as to get optimum weight gain according to her pre pregnancy weight. For PIH, we should take preventive actions. That means we should start low dose aspirin as early as possible, means at detection of viable fetal pregnancy. Maternal health, definitely frequent follow ups are needed. So, what is the best way? We have seen so many complications which may occur. So, best way is the planned conception. That means our patient should use contraception while she is having uncontrolled hyperglycemia, means uncontrolled diabetes is there. During that period, we should advise her proper, appropriate contraception, and we must counsel her about planned pregnancy and its good outcome because we know it has advantages of adequate blood glucose control, additional monitoring of complications of diabetes, and we can optimize concomitant medication and optimize health parameters, weight, BP, and lipids prior to pregnancy, and optimize her psychosocial health. In general, in practice, we should be vigilant if someone is married and she has to start her family or she has to complete her family. In those cases, we should give fetus friendly medications. Means we should avoid medications which can lead to teratogenesis in unplanned pregnancy. So we should be vigilant about it. Although our patients tell we are using regular contraception, doctor, I don't know how it happened, but once it has happened, we have to bear all the brunt of its happening, means conception. So management, we have to decide that should be in a teamwork, and the captain is patient and her immediate family member who has to take care of her, and we are just there to guide her and give her best advice and best support when it's about continuation or termination. And we have to see whether it needs immediate termination or it can be delayed. Means for congenital malformations, the thanks to the Indian government and the MTP laws, we can just wait for some time where it is according to regulations we can postpone the termination of pregnancy after confirming whether it is really needs termination, and we have to discuss about the mode of termination whenever we need to do it. Maybe it's for early termination, means DNC versus empty pills, or late termination means delivery, vaginal delivery versus cesarean. So all these things we have to consider. Termination is needed for unwanted, unhealthy, or unsustainable pregnancy, or if there is clear-cut fetal or maternal risk. So MTP laws is liberalized till 24 weeks of gestation, but even after that, if there is uh, the fetal complications, means there is congenital malformation which is incompatible with life, with the panel we can go for termination later also with the permission of medical board. So what to do in the gray zone? When patient wanted a pregnancy, this pregnancy has occurred after so many challenges. Might be she was having a PCOS patient, it was difficult for her to conceive, and suddenly she gets the urinary pregnancy test showing the two lines. So that means this is a very precious pregnancy for her. This was unexpected for her, and she got it. No evidence of congenital malformations is there, and there is no clear cut maternal ill health at present, although her HbA1c maybe it's around 10 or 11 or so. So what should be done? Should be done in the gray zone area. So here comes the role of shared decision making. That means we have to assess and analyze the situation and explain the risks and benefits of each and every management, inquire about her psychosocial aspects, and offer her various options and understand opinions of all the stakeholders. Maybe we need to consult a nephrologist or eye ophthalmologist for this, or a pediatrician. So all these things are to be in consideration, whether we are planning for early delivery, or if we have NICU facilities sufficient to manage the 32-weeker baby or 28-weeker baby. So all these things should be discussed with the various stakeholders, and we should arrive at the course of action, explain the plan and procedure, and initiate therapy as decided. Sometimes patients say, I don't want to start insulin now. I want to see whether I can continue this pregnancy or not for some time. I will take time to decide. I will come to you after a week after deciding and discussing with my family members. Till that, I want to continue OHA. So, what should be done in those situations? We should be open to change as far as possible, and we should give them Uber services and motivation whenever they want, and what is the best advice for them should be given to them. So once we have seen the pregnancy is viable and patient needs to continue it, or even if she has to decide later, then at this stage we should stop ACE inhibitors, ARBs, and statins. Although, even if someone has taken ACE inhibitors in early first trimester, it's not that that needs termination. We have to stop it at that stage because the risk of congenital malformation is not as high as for ARBs. And statins, these should be stopped. Shift to the appropriate insulin or metformin depending on her blood glucose levels. Might be she was on MNT prior to pregnancy and now her hyperglycemia is slightly worsened and she needs OHA. So all these things should be in discussion with the patient. Target HbA1c should be as low as possible without any incidence of hypoglycemia. Fasting should be less than 90 or 95 milligram percent. 1 hour post meal 140 and 2 hour post meal less than 120 milligram percent. So these are our targets which we have to achieve as early as possible and as low as dose of the insulin is needed for it. So we have to make the combination of different regimes. Means we have to follow the ADA standard of care guidelines for achieving these our targets, and we have to start the low dose aspirin. Aspirin 75 milligram at bedtime is the best regime to start because in such patients risk of placental pathologies are high, leading to various pregnancy complications like PIH, IUGR, or oligohydramnios, or abruption, APH. So all these kinds of complications are more common in such patients because in early pregnancy, if placenta is not formed well because of hyperglycemia, so the complications are seen in late second and third trimester. So we want rapid and tight glucose control and strict medical monitoring. That is to be continued throughout the pregnancy. Obstetric vigilance should be there. We should be prepared for any untoward event. That means we have to give her the for fetal lung maturity. We have to give her the injection of steroids. That is the dexamethasone or the betamethasone. So these kinds of injections we need to give. Although we know that we may be able to continue pregnancy till term and the effect may not be needed, but we should be prepared for that. We should be proactive in interventions, and informed and shared decision making should be there. And above all, documentation is very important. Whatever we are deciding, whatever we are doing, why we are giving her any medication, we have to explain to the patient and we have to document. First of all, we have to save ourselves also. So, because at times, even if we tell them verbally, the patient says, Doctor didn't tell me. So, that kind of problem shouldn't arise. So, the documentation saves us many a times in the medical legal cases. That is a very important aspect because maternal complications like spontaneous miscarriage rate is very high, preeclampsia, polyhydramnios, preterm delivery, or patient may need operative or traumatic delivery. So that may be needed. Patient says that doctor go for instrumental delivery, but when some complication occurs, doctor you could have done the cesarean at right time also. So these kinds of problems are there while taking the decisions. And if there is rapid progression of micro or macrovascular complications that may occur in pregnancy, so we have to be regular with her visits to expert specialist. Unpredicted glycemic variability, that is very, very common. Sometimes patient says that I had taken insulin, but I didn't like food, or I got vomiting. So she may get hypoglycemia. Or someone was eating sweets, so I had taken just peas. Doctor, I had taken just prasad. What happens with the prasad? The temple person gave me the blessings in the form of prasad, and I had taken it. The halwa she had taken, that has made its blood glucose levels uncontrolled, and it is rising and rising. Because the small trigger can worsen the situation anytime. These patients are prone to recurrent genital infections and UTI. So, if someone is coming to you with the repeated episodes of hyperglycemia and she is reassuring you she is taking full care, must rule out genital infections and UTI in her. And coming to the fetus, we know the specific to uncontrolled hyperglycemia, many complications are there. If we talk about the cardiovascular, the transposition of great vessels is very, very common. So that means, irrespective of age, irrespective of duration of diabetes, and irrespective of her HbA1c levels, we must get for all these patients fetal echo at around 20 to 22 weeks. She may be having, the fetus may be having acrania or anencephaly, so neural tube defects may be there, skeletal system defects may be there. So some of the defects are not detectable early in pregnancy or by we get her TIFA scan, means anomaly scan is done. By the time they are not appearing. But if we get late ultrasound, maybe around 24 weeks or so, so sometimes the ultrasound report writes in one of my patients it was binder facies. So her attendants became furious. Why didn't it was detected? So in our consent, we have to write some anomalies are not detectable during ultrasound, and some evolve later. So that has to be explained to them. Renal and GI problems can occur in this phase. And if HbA1c is around 6%, the risk of anomaly is around 3%. So that is as normal as for the general population. So we are not worried about it. But if HbA1c rises to 15%, so risk of anomaly increases up to 40%. So if someone is coming with HbA1c 15%, so we have to weigh and we have to counsel her. She might need, high likely she will need termination of pregnancy because of fetal anomalies. So in my OPD slips, I write about the risk of uncontrolled hyperglycemia to the developing fetus and the congenital malformations occurring because of that. And some of the anomalies may not be detected on ultrasound or evolve later in pregnancy. So this has been explained and documented in records with their signature that they know about it and they want to continue in spite of all this. But as the pregnancy evolves, with the time, birth defects may be visible or she may land up in preterm labor, or her hyperglycemia led to the PIH, pregnancy-induced hypertension. So, and that has worsened. Preeclampsia is there, so in that case, we may need to go for preterm delivery. Miscarriage or stillbirth are common, and macrosomia and IUGR. These are the two different spectrums. Sometimes, if placenta is very much affected with the hyperglycemia, so chances of IUGR are high. But if it has worsened after mid of pregnancy, means around 20 weeks of pregnancy, if the hyperglycemia was there at that time, even if we control blood glucose levels in later half of second trimester or third trimester, even then the macrosomia may occur because a trigger of pancreas, fetal pancreas has started, so that will lead to macrosomia. Even if we try to control it, we are not able to control it. So that is why we need repeated growth scans for fetal growth and IUGR. It's not like that if macrosomia is there, only in those cases hydramnios will be there. At times, IUGR with hydramnios can be seen in such patients. So that is why we need repeated ultrasounds. And while trying for vaginal delivery, we may end up with shoulder dystocia and birth injuries in our fetus. So after birth, there are chances of hypoglycemia because mother was taking insulin, and because of that, the neonate gets hypoglycemia. So we have to tell them about the repeated feeding and repeated blood glucose monitoring of the baby, newborn. So for 24 to 48 hours, usually the neonate has to be under intensive care and intensive monitoring to rule out any hypoglycemia. Chances of respiratory distress are high, neonatal jaundice, and NICU admission is usually needed. So, what is the algorithm? We have discussed all the aspects. So, how can we clearly, means for anyone who has to decide how to decide whether she should continue this pregnancy or not? So, first, if the risks are low in this particular pregnancy, then we advise her to continue. But if risks are high, then we tell her to go for termination. But in some cases, because of her psychosocial factors and her desire to continue pregnancy, we defer the decision unless any complication arises. Like if fertility and fecundity are low, then it's better to continue pregnancy. Like in cases of PCOS or her AMH level is very low. If societal pressure is high, then she should continue pregnancy because her husband, that is their first pregnancy, and it has conceived after a long year of infertility. So she has a social pressure from her family, her partner, that she needs to continue it. And she has psychological resilience. She should continue. Sometimes, doctor, if something happens to my child, I will not survive. I will not be able to live in this family. So in those cases, we have to take the decision accordingly. If HbA1c is less than 8.5%, as there are chances of congenital malformations are not as high if it is more than 12%, so she can continue. We have to tell them, even if the risk is 10%, there are chances that 90% of pregnancies will continue well, there will be no harm. If she has not taken any contraindicated medication, she can continue well. Microvascular health, macrovascular health, all are good, and fetal health is optimal. Then we suggest them to continue pregnancy. And but if these things are otherwise, then we suggest termination. But if there is early retinopathy or early nephropathy or hypertension is there prior to pregnancy, then we defer the decision. If there are any complication, then we will do it. And for fetal health, if there is borderline growth trajectory, then even then we have to defer the decision of termination. So we can divide it and decide it in simple way. If there are psychosocial aspects are optimal, means legally we can do termination at later gestation, just like at 24 weeks of gestation, or the system specific. If the facilities are available for termination at a later stage, then we should continue. And her emotional and economic health supports that she can continue, and she can bear the burden of that taking care of that pregnancy financially as well as emotionally. And if her obstetric health and offsprings are in our favor, metabolic and medical health are in our favor, in the favor of continuation of pregnancy, then we should continue this pregnancy. Just to summarize, I find it is more common than planned pregnancy, especially for diabetic women. And prevention is the best, and management needs person centered approach. Some of the cases are clear cut, but gray zone cases needs individualized decision making. So, the effect of unplanned pregnancy or uncontrolled hyperglycemia at the time of conception, that affects conception means conception may not happen, or if it has happened, it may affect embryo means missed abortion can affect fetus and newborn complications we have seen. And even all the phases of life are affected. Infant, toddler, they may get childhood obesity, and later on they may get diabetes. And in adulthood also, the risk of metabolic diseases, non-communicable diseases is very high. So womb to tomb, we are affected with unplanned pregnancy and diabetes. But if we and our patients take good care of themselves, we can climb this mountain and reach at its top. Thank you.
Thank you, ma'am. Thank you so much for such an insightful talk. Ma'am, with your permission, can we take the questions?
Sure.
Ma'am, would you like to have some water?
Yeah.
Yes, just give me a minute, ma'am. Ma'am, the first question is, what are the key challenges in managing an unplanned pregnancy in women with pre-existing diabetes, and how can the healthcare providers address them effectively?
The challenges are first, one is the what is her status of hyperglycemia, means her HbA1c level and her current blood glucose levels. If HbA1c level is very high, the risk of because the if uncontrolled hyperglycemia is present at the start of pregnancy, so risk of congenital malformations is very high, and risk of spontaneous miscarriage. So in early pregnancy, these risks are very high. So first of all, we have to check her HbA1c, and if she is having long-standing diabetes, then we have to look for her complications of diabetes and whether she is taking any medication for it or not. And we have to discuss about the continuation versus termination. So that is the main challenge. And we have to tell her that this is a like climbing a rock. So you are the captain and you have to take us for this journey. So at start in the first visit, HbA1c, her blood glucose levels, and if it is a long-standing pregnancy, long-standing diabetes, then rule out other complications like microvascular complications, nephropathy, retinopathy, and macrovascular complications. Like we have to look for her blood pressure, lipid levels.
Right, ma'am. Thank you so much for answering the query. Moving to the next question. Ma'am, what are the essential preconception counseling points that should be reinforced even for women who may not be actively planning pregnancy?
From patient point of view, for our good health, we need good glycemic control. So that she lifestyle for achieving good glycemic control is she had to take care of her diet, exercise, and her three stresses means stress, sleep time, and screen time. Nowadays in lifestyle, these things have taken a lot of toll. Means the sleep is decreased, screen time is increased, and stress levels are very high. So these things lead to worsening of her glycemic control. Even if someone is planning or not planning pregnancy, for her own good health, she needs good glycemic control. And she should increase her protein intake and reduce her fat and carbohydrate intake. So that will help her own health as well as whenever she plans pregnancy, the pregnancy will be in good condition. and we have to maintain our BMI also. So these are the essential parts of taking care of. In general, we say if you take care of your weight, your BP, your hemoglobin level, and blood glucose levels, and from clinician point of view, your thyroid status. If these five essentials are maintained, chances are your pregnancy will be in good condition, and outcome will be good.
Right, ma'am. Ma'am, one last query, that is, how should insulin therapy or oral hypoglycemic agents be adjusted once an unplanned pregnancy is confirmed? And are there any specific precautions to be taken?
That depends upon patient's condition. So, because the ADI guidelines, because that is in itself that is a full topic, that how to start and how to start and how to manage and dose adjustment for the insulin. We have to see her HbA1c level and her fasting blood glucose levels and postprandial blood glucose levels. What is her meal pattern? Which type of meal she is taking. Accordingly, we start her dosage. Means if her hyperglycemia is not bad and she is in second or third trimester, that depends upon the timings. In first trimester, we want good control with insulin because the metformin is not that takes time to control blood glucose levels and that is not approved to be taken in first and second trimester. According to guidelines, that can be started after 20 weeks of gestation. So prior to 20 weeks, we have to control hyperglycemia to achieve the target of fasting less than 90, 2 RPP less than 120 with the insulin. Or if someone can manage with medical nutrition therapy, then it's also okay. Because medical nutrition therapy means the all the dietary plan she has to follow first, and then we add to it the insulin treatment. So if hyperglycemia is not much, she is getting fasting hyperglycemia and postprandial blood glucose levels are in the normal range or near the normal range. Then we start insulin at bedtime or with dinner. Long-acting insulin is started. But if postprandial blood glucose levels are high, then we start with meal, low dose, fast-acting insulin is started. So different regimes for different patients. That is to be individualized. We can't generalize it.
Hello, ma'am, am I audible?
Yes.
Yeah. Right, ma'am, just let me check if there are any other queries, or else we'll wrap up the session for today.
Human insulin and analogs both can be used during pregnancy. Yeah, specific analogs are safe.
Right, ma'am. Thank you, ma'am. Thank you so much for answering all the queries that have come from audience. And ma'am, before wrapping up the session, I would like to thank you for giving your effort and like making such a beautiful presentation and solving all the queries. So thank you so much,
Thank
ma'am, once
you.
again for joining in. Thank you. Thank you,
Okay,
all the
thank you.
attendees. See you in near future. Thank you all.
Thank you. Okay.